faithfully delivering value by interpreting great books from around the world. Hi, this is Sally here with Book Talk. Today, we're interpreting the book Betrayal, subtitled The Collapse of the Public Health System for you. Do you know what public health is all about? Feel free to leave comments and discuss with us in the comments section. Public health is a public undertaking focused on the well-being of the masses. Its work includes preventing and controlling major diseases like tuberculosis, influenza, and AIDS, as well as overseeing food, drug, and environmental safety, plus public health education. Public health affects everyone's health and safety. So, what happens when this system breaks down? What causes a public health system to fail or even collapse? That's exactly what this book explores. The author, Laurie Garrett, is a renowned American science journalist and best-selling writer in health and epidemics, known for works like The Coming Plague. In 1995, he won the Pulitzer Prize for Journalism for covering the Ebola outbreak in Zaire. And he's also the only person to win all major U.S. journalism awards, including the Pulitzer, Peabody, and George Polk Awards. In Garrett's view, public health is a trust bond between government and people. The public entrusts government to protect collective health, while individuals cooperate through taxes, vaccinations, and following rules. If either side betrays that trust, the public health system crumbles. In today's book, Betrayal, Garrett takes us to India and Africa to examine when an outbreak hits, what makes local public health systems betray public trust and even fuel the epidemic. He also traces public health history in the Soviet Union and US, searching for reasons behind system failures. The book has 6 chapters and 802,000 words. After its 2000 publication, it was nominated for the National Book Critics Circle Award for Best Nonfiction Book. It also received recommendations from many media outlets and Nobel Laureates. Notably, though written over 20 years ago, many issues in the book still serve as warnings today. In 1999, James Orbinsky, Nobel Peace Prize laureate, doctor, and humanitarian activist, said that if healthcare is a right for all, not a privilege for the few. So, any responsible citizen, health expert, and rights advocate must take global public health seriously. The alarm Garrett sounded in the book is both brilliant and visionary. All right, I'll split this into 2 parts to interpret the book's main content for you. In the first part, we'll start with India and Zaire to see what happens when public health systems are missing during an outbreak. In the second part, we'll focus on what causes public health systems to fail and the challenges they face today. Okay, in the first part, let's head to India first. Back in September 1994, plague panic swept across India. In Surat, a western port city, people wore masks, lugged their bags, elbowed through crowds to cram onto trains, desperate to flee the plague-stricken city. Within days, over half of Surat's 2.2 million residents fled. Once noisy factories fell eerily silent. Cows wandered the streets scavenging trash. Pharmacies and private hospitals had their doors nailed shut with planks, and residents trapped in the city, covering their faces with masks or rags, rushing through the streets. The Gujarat health chief called the plague's arrival a bolt from the blue. It was so sudden. He explained that the plague pathogen is Yersinia pestis, a bacteria that hides in fleas' guts, blocking food flow, making fleas ravenous and aggressive. Fleas feed on blood and often live on rats. Once it contacts human cells, Yersinia pestis releases chemicals that cripple cells' normal functions and secretes proteins that block immune defenses. If it invades skin cells and lymph systems, it causes bubonic plague with swollen lymph nodes. Boils appear on the skin, oozing thick yellow fluid. Early in infection, cheap antibiotics like tetracycline or doxycycline can beat Yersinia pestis. The cure rate is almost 100%. But if it advances, treatment gets tough. It enters the blood, causing sepsis. It also damages the heart and liver. If it invades the lungs, it leads to pneumonic plague. Pneumonic plague spreads through the air, making it the most dangerous form. India reported its last human plague case in 1966. It didn't reappear until 1989. 23 years later, 3 human plague cases emerged. In 1991, India recorded 50 human plague cases. By 1992, it reached 135 cases. Yet this rising trend was ignored. Also overlooked was a key trait of Yersinia pestis. It can lie dormant in soil for extended periods. A 6.4 magnitude earthquake in southeastern India in 1993 awakened dormant Yersinia pestis there. On September 30th that year, the quake struck Latur in Maharashtra's east, killing over 10,000 people. Around Latur, roughly 10,000 villages were destroyed and 1 million homes collapsed. Survivors stored harvested grain in intact houses before fleeing their homes. With World Bank's support, the Indian government built relocation housing on the quake site. When villagers returned in summer 1994, they found plump rats everywhere, carrying fleas and Yersinia pestis. By August 1994, locals began showing bubonic plague symptoms.
On September 14th, India's health ministry confirmed 4 bubonic plague cases, with more emerging.
But the quake had destroyed health infrastructure. Medical staff fled, clinics were flattened. Local authorities couldn't diagnose or treat all bubonic cases, enabling the plague's spread. The author contends that, even without the quake, the outcome wouldn't have differed much. Because while India's economy grew, it drastically cut public health spending. In the early 1990s, India's economy grew 4% annually. In 1991, manufacturing grew by $40 billion, making it a top third world producer. Yet in 1992, public health spending was just 0.04% of the budget, less than a tenth of a decade prior and 1/20th of military spending. The following year, India's public expenditure budget was cut by another 20%. In 1994, about a quarter of Indian children hadn't completed UNICEF-recommended vaccinations. Infant mortality was 10 times that of developed countries, and average life expectancy was just 59. Against this backdrop of severe underinvestment in public health, Indian states neglected plague surveillance for years. In the 1980s, the Indian government gradually shut down plague monitoring stations, stopped searching for cases, and halted random testing of rats and fleas. I knew when the outbreak suddenly hit, Indian officials chose to downplay its severity. Even when 6 districts in Maharashtra reported 317 bubonic plague cases, officials, including India's health minister, insisted there was no need to worry. But the plague had already spread and would turn Surat, an industrial city 600 kilometers away, into a ghost town. Surat epitomized India's rapid economic development. In the early 1990s, the city had a $600 million textile industry and a $1 billion diamond industry. As mentioned in our previous episode on the Stone of Desire, Surat is a major global diamond processing hub with what's billed as the world's largest polishing factory. And from 1971 to 1991, Surat's population surged by about 15.1%, mostly poor migrant workers from across India. As population grew, slums multiplied, from 90 in the 1960s to 300 by 1994. Some 450,000 people crowded into shacks or tents without proper sewage or water systems, where malaria and hepatitis ran rampant.
In summer 1994, Surat endured 87 straight days of torrential rain, causing rivers to overflow and flood slums, especially the hardest-hit areas.
In Ved Road, most residents were migrant laborers. 10 to 20% hailed from Maharashtra. At Ved Road, where plague first emerged, one toilet served every 150 people. Open sewers reeked of stench, and downpours flooded rooftops, forcing many to flee to drier city areas overnight. In early September, the floodwaters finally receded from Ved Road. On September 18th, the important local festival, Ganesh Chaturthi, arrived. People flooded the streets, carrying statues of Lord Ganesha, dancing and singing in parades to celebrate. Among the crowd, at least one person was a plague carrier from Maharashtra. Yersinia pestis had invaded his lungs. He coughed while celebrating. On September 20th, the day after the Ganesh Chaturthi parade, Surat's public hospital discovered a death case. By September 22nd, 13 people had been confirmed infected, with 7 dead. They all came from the slums of Ved Road, all had bilateral pneumonia with bloody sputum. Plus, the illness history was short, less than 4 days. The Indian government failed to provide any real help to Surat's public hospitals at the outbreak's start. Doctors at public hospitals hoped private doctors in Surat could lend a hand. During India's marketization, many sectors like healthcare got privatized. By the mid-1990s, India's basic public health infrastructure was vanishing, with over 75% of medical services from individual doctors.
But most private doctors lacked proper training, and their treatments might be seen as illegal in Western countries.
Worse, upon hearing the news, 80% of private doctors fled first. They shut clinics and hospitals, abandoning patients. This sparked panic, kicking off a mass public exodus. Ordinary folks saw the doctors' panic behavior and started rumors of a looming catastrophe. Private doctors also fed the media false info, and exaggerated reports ramped up public panic. For instance, on September 22nd, a Mumbai newspaper wrote, "A private doctor in Surat confirms 45 deaths. Actual toll could top 80. As we said earlier, only 7 death cases were found in Surat that day. The same day, the British Broadcasting Corporation, or BBC, reported Surat had an outbreak of a mysterious, deadly disease. Half a day after that report aired, 100,000 Surat residents fled by train. The next day, about 300,000 queued to board trains with handkerchiefs over their faces, and Pray X was headed. False news spread everywhere. India Daily claimed over 250 Surat deaths and 10,000 plague infections. One report stated half a village had died of plague. Rumors claimed all Surat residents were infected. Amidst rampant rumors and panic, India's government did nothing to stop Surat residents fleeing. When India's Rapid Action Force finally arrived September 24th to quarantine Surat, 450,600 had already fled isolation. Efforts were sluggish, aid delayed. Crucial epidemiological investigations stalled too. Despite clinical signs pointing to plague, lab confirmation only came in February 1995, 6 months post-outbreak. The outbreak was caused by Yersinia pestis. India's National Institute of Infectious Diseases plague lab was dilapidated, equipped like a U.S. high school lab. Western-trained microbiologists sweated in plastic suits without AC. The institute was focused on fighting another epidemic. 60 staff had died of hepatitis E, spread via fecal-oral transmission. This prevented timely epidemiological or lab evidence. Without clear, scientifically validated statements, conspiracy theories exploded, shattering health authorities' credibility. When U.S., French, and Russian experts identified it as a new Yersinia strain, rumors spread. Kazakhstan made this bioweapon. U.S. Embassy in New Delhi got surrounded.
The U.S. ambassador faced attacks after Indian scientists and journalists claimed this engineered strain was made by Americans.
Mumbai rumors blamed Pakistan. In Kolkata, people believed the government hid death tolls. Real numbers were far higher. Overall, Indians seemed to believe everything except government statements, leading directly to antibiotic abuse. Within a week of Surat's outbreak, tetracycline sales in India soared. Gujarat alone consumed over 10 million tetracycline doses. Health authorities told people tetracycline was unnecessary unless they'd contacted plague cases and showed symptoms. But Indians ignored government announcements. Antibiotic abuse bred microbial resistance, while panic triggered economic collapse.
On September 28th, Gulf nations like Kuwait and Qatar banned all flights, cargo, and citizens from India.
Pakistan and Sri Lanka quickly followed suit. The stock market
suffered its biggest single-day drop since the 1989 assassination of former Prime Minister Rajiv Gandhi.
Then Russia, Egypt, Malaysia, and other key trade or tourist partners cut all ties with India. While Europe, North America maintained ties, they required passenger health checks. The U.S. CDC plague hotline got nearly 2,700 calls from September 27th to October 31st. Callers were anxious, some hysterical. The world seemed to forget humanity had conquered plague. Yersinia pestis plague is curable with antibiotics like tetracycline. By October, India became a global target with increasing punitive measures. Bombay's stock market fell 213 points in 1 month, a 5% total value loss since Surat's outbreak. All over India, people trapped rats, cleaned streets, burned garbage, creating smog and choking rot everywhere. Hundreds of kilos of DDT pesticides sprayed in Surat alone. New Delhi's Mahatma Gandhi statue got a giant mask. In Maharashtra, a man murdered 3 outsiders, he accused of carrying plague. The youngest victim was 7. The outbreak didn't end until late October, with a total of 65 deaths and about 6,500 infections. Based on loss estimates from various sources,
India's losses in tourism and trade alone reached a staggering 1.3 billion US dollars.
if we factor in the shutdown losses in Surat's textile and diamond industries, agricultural production losses in Maharashtra, panic buying of antibiotics, and direct medical costs incurred, the total estimated loss from this plague outbreak is nearly 2 billion US dollars. The author points out that compared to the actual infection and death toll, and the fact that plague is fully treatable, such a cost is far too high. All right, so far we've covered the 1994 plague outbreak in India. The lack of public health infrastructure not only prevented India from detecting and identifying the resurgence of plague early on, but also hindered timely, effective treatment. Public distrust in the government, fueled by rumors and conspiracy theories, further eroded governmental credibility. Ultimately, the whole society plunged into panic and paid a huge price for it. A year later, in the African country of Zaire, now the Democratic Republic of Congo, Ebola broke out. This outbreak would further prove that inadequate public health infrastructure can turn hospitals, which should heal, into catalysts for epidemics. Next, we'll delve into exactly how this happened. In 1995, Zaire, public health and medical infrastructure were virtually non-existent. Only 42% of the population had access to near-safe drinking water. Just 15% had public health and waste disposal services, and there was only 1 hospital bed for every 24,000 Zaireans. More importantly, since the 1991 riots in Zaire, civil servants, including over 95% of doctors and nurses, hadn't been paid.
To make ends meet, many medical staff sold hospital supplies on the black market.
Items like latex gloves and x-ray films, these essential medical supplies, vanished from many hospitals and clinics. When Ebola broke out in Kikwit, a southwestern city in Zaire, in May 1995, hospitals there had no running water, no disinfectant or soap. Surgical instruments were sterilized by boiling, and latex gloves and gowns were reused. With scarce electricity, surgeons relied on sunlight from windows to operate on patients, similar to India's 1994 plague outbreak. The Ebola outbreak in Zaire also first occurred in rural areas. A local charcoal maker named Menga was cutting trees and burning charcoal in the rainforest near Kikwit. In January 1995, Menga contracted Ebola and died. Soon, his family and relatives who attended his funeral also fell ill and died. Most of Menga's relatives came from small villages near Kikwit. Ebola ravaged their villages for 2 months before disappearing.
But in Kikwit, the situation was different.
In April 1995, a lab technician named Kim Fumu at Kikwit's second maternity hospital contracted the virus while drawing blood from several patients.
At that time, no one knew Ebola had arrived. Kim Fumu's belly swelled up.
Doctors thought he had a gastrointestinal disease and performed 2 surgeries on him, but neither could save his life. And these surgeries became a major outbreak point for the epidemic in Kikwit. Almost everyone involved in the surgeries later contracted Ebola and died. But before that, they would travel to see their families and care for patients. In mid-May, an international medical team that arrived finally confirmed Ebola was the cause. They believed local medical institutions acted as catalysts for Ebola spread. Poor sanitary conditions turned isolated hospital cases into a full epidemic. Doctors Without Borders, who arrived in Kikwit, knew that stopping Ebola wasn't about high-tech equipment, but basic essentials like soap and protective gear. A Doctors Without Borders member named Gil Stein requested supplies like respirators, masks, protective suits, and disinfectants from the Brussels headquarters. He created a work schedule so all medical staff could get adequate rest. He also provided safe drinking water and food for the staff. Through Doctors Without Borders efforts, by mid-May, the spread of infection within the hospital had stopped. In August 1995, WHO announced the end of the epidemic in Kikwit. This outbreak caused 296 deaths, with one-third being healthcare workers. Unfortunately, by the time the author wrote the book, the public health situation in Zaire seemed to have worsened. In 1998, medical supplies in Kikwit were not only scarce but also much more expensive than in 1995. This place had only one ambulance, which was commandeered by Bandunu province where Kikwit is located. The provincial governor requisitioned it. That portly governor had it repainted, installed sofas, turning this Ebola-transporting ambulance into his personal luxury limousine. The book notes that from 1986 to its 2000 publication, hemorrhagic viruses like Ebola broke out at least 13 times in Africa. Almost every initial case was detected long after the virus had spread. Experts believe better disease surveillance is crucial. Without a fundamental public health system, you can't build a detection system. According to a 1990s UNICEF survey, 48% of countries allocated less than 10% of their budgets to public health services, yet served over 4 billion people. When major public health crises hit, the consequences can be devastating. So far, we've seen how missing public health systems in India and Zaire caused crises. But this isn't just a third world problem.
The author notes public health infrastructure has weak resilience. Under social or economic pressure, it collapses quickly with immediate health impacts.
In part 2, we'll follow the author to former Soviet Union and US to explore what undermines public health systems and 21st century challenges.
After hearing about India's plague and Zaire's Ebola, what are your thoughts?
Feel free to share in the comments section.
All right, that concludes part 1 of Betrayal. Reading notes below the audio. See you next episode.